Okay, we're going to do our today's lecture is going to be on respiratory, and I'm thinking I'm going to do this in 3 different videos. The first one's going to basically be this one is covering the respiratory system, diagnostic testing and procedures, the assessment of the respiratory system, and airway management. Okay. Although some of this may seem like a basic review for you, I think it's very important to understand exactly what's going on assessment wise so that you'll be able to take care of upper and lower respiratory disorders. So the first thing I want you to do is have a basic understanding of the anatomy of the respiratory system. When we refer to the respiratory, the upper respiratory tract, we are thinking about the nose, the mouth, sinuses, and that part. So your nose basically sits on your face, humidifies the air that comes in, warms the air up, and filters. You know, you have your nose hairs and they kind of keep things from coming in. Your sinuses are air-filled cavities, and believe it or not, they actually help out with speech. You have your pharynx, and your pharynx is a passageway for air and food, and we refer to it as your throat. And then you have your larynx, which you've heard many people call your voice box, and it houses your true and false vocal cords. You have your epiglottis. It is a cartilage flap. It's attached to the top of the larynx, and it actually prevents food from going into the trachea. In its upright position, that's how it is at rest, and when you're swallowing, it kind of folds back over. When we refer to the lower respiratory tract, we start thinking about your trachea, and your trachea is the long windpipe, I'll say, with the cartilage rings in it. And it sits in front of the esophagus, and it divides further into your right and main stem bronchi. The main stem bronchi starts at the carina, and it has a right and a left side. And the right side, and I think this is very important for you to note, the right side is wider, straighter, and shorter than the left main stem bronchi. And that's usually where things like foreign objects get stuck, or even when we're trying to intubate a patient, the ET tube may go a little slightly to the right because it's a straighter path. Further goes down into bronchi, your bronchioles, and then we have your alveolar ducts and on over to your alveoli. This is going to be the most distal end of the lower respiratory tract. And we have those clusters of alveoli, and that is where gas exchange happens. And that's very important for you to know. We're going to think about that as being, that is where the magic happens. And when I say gas exchange, I want you guys to understand what I'm saying. You are going to take oxygen into the blood and bring CO2 out so you can blow it out. Another important fact to know about the alveolar is that is where surfactant is created. And surfactant is very important because it actually reduces the surface tension area in there, and that makes gas exchange easier. Okay, so and it also keeps, the surfactant keeps a certain amount of pressure in the lungs so that they don't stick, collapse and stick to each other. So surfactant is very important. And if you happen to be thinking about, and I don't want to step outside of my scope talking about the pediatric patient, but when you think about your pediatric patient, if they come here premature before around 20 weeks of life, they haven't fully developed that surfactant that is needed. So they're going to have issues with oxygenation. And that's my little side note. That's all I know about the little babies. So then we're going to have your lungs. So obviously the lungs are at the bottom. They're going to start at the clavicles, and they work their way all the way down to the diaphragm. They're the major muscle in respiration. The right lung is larger than the left. It has 3 lobes, and when we identify those 3 lobes, we call them the upper, the middle, and the lower lobes. The left only has 2 lobes to make room for the heart. And one of the things I think you need to know about that is The innervation of all of the respiratory functions is done by the phrenic nerve, the vagus nerve, and the thoracic nerves, okay? So, and I'm going to touch back on those, the phrenic nerve, so that you'll know exactly what I'm talking about. Accessory muscles. There are muscles that we don't necessarily think about because we always just think about the lungs and we think about the intercostal muscles. And the intercostal muscles are going to be the muscles that's in between each of the ribs. But the lungs also have some accessory muscles that help out with breathing. And the accessory muscles, the first one I want to talk about is going to be the scalene. It's in the front of the neck. And then we have the sternocleidomastoid. It goes from the top of the clavicles all the way up to probably the back of your ears. You have your trapeze, which are in the back, and your pectoralis, and those are your pecs in the front. And those are all those muscles that pop out in your neck when you are angry. So I definitely wanted to bring in the accessory muscles. Of course, you know, when you're thinking about your rib cage, you think about your 12th layer of ribs. We don't want to forget about that part. And then the diaphragm. The diaphragm is very important. We occasionally like to ask questions about the diaphragm. It separates the thoracic cavity from the abdominal cavity. It flattens during inspiration. And like I said, the phrenic nerve actually helps out with all of that. And that allows for greater chest expansion. We can't talk about the respiratory system without talking about age-related changes. Okay, so like I said, I'm giving you this basic overview. These are those concepts that you kind of got to know in order to move forward. As we think about aging and the changes that go on, we have to think about the fact that we're going to have a decrease in the immune system, the decrease of its response as you get older. So that's going to leave our patients to be more susceptible to upper respiratory infections, okay? They have a decrease in cough and an increase in potential to aspirate, because remember, our cough is our body's natural mechanism to protect our airway. As you get older, there is an increased likelihood that you will have some osteoporosis, and with that you may have kyphosis. And if a patient has some kyphosis and they're hunched over, that's going to inhibit lung expansion. You're going to have some decrease in elasticity. And when you think about that, basically, I'm going to say you're going to have a decrease in compliance. And compliance is the elasticity of the lungs. So that means the lungs are going to be stiffer. As you get older, and obviously stiff lungs are not going to inhale and exhale the way they're supposed to. As you get older, you lose your body water percentage. So right around 70 years old, you have lost about 50% of the body water. And that's important because now we have thicker mucus to cough up. And like I said, you have a weaker cough. So now you have this thick mucus and you can't cough it up. And anytime we have fluid or mucus, that's going to be a medium for bacteria to grow, and that's all that is bad, bad, bad. You're going to have membranes that aren't moist, so they can crack, which is going to be breaking down the defense mechanism, letting in nasty germs. Impairment of ciliary action. When you think about that, I want you to think about the little hairs that are in your nose. Well, you have little hairs that line your respiratory tract, and they help out with movement, and they help out with also filtering. And if this is not moving, it may not filter accordingly like it's supposed to. Your loss of normal elastic recall during expiration, that's going to increase the work of breathing. That is how well the patient can breathe. So, you know, we always call this dyspnea on exertion or dyspnea at rest. That's what I'm talking about. They look like they're working so hard to breathe. Muscle atrophy. Muscles are breaking down. They're not moving the way they used to 60 years ago, 50 years ago. So you're not walking as much. You're not exercising as much. So you start to have some diminishing in their strength and stuff. You also have a decrease in response to hypoxia. And hypoxia is going to be a decrease in oxygenation at the tissue level. So there's lots of things that are going on as you age that affects your respiratory system. And I wanted to make sure to cover some of those because you need to know this as if you're dealing with your elderly, geriatric population, your pediatric population, or you are dealing with your adult. Now we need to figure out exactly what is the job of the respiratory system. So you guys have the slides. You can look at them and come up with what you need. But basically, the respiratory system provides oxygenation and tissue perfusion. Okay, it it removes carbon dioxide, which is the waste product of metabolism. So your lungs take in this great oxygen. Remember, we talked about the gas exchange. The oxygen that is taken in has a delivery system, and the delivery system is the heart. It delivers all the oxygen to all the organs and the tissues that need it, and the actual transporter is going to be red blood cells or your hemoglobin. Okay, so this is the role. Its role is to get rid of waste products, oxygenate, and tissue perfuse. It has some secondary functions, and I don't want to look over that. It helps out with speech, smelling, and acid-base balance. Okay, and if you need a little refresher on acid-base balance, we also have a video up for that one as well. So your question to me is, so I know what the job is, but how does it do the job? How does the respiratory system perform its job? Well, one of the things I want you to know is all happens because of the movement of the diaphragm and the accessory muscles. Okay? So, and all of that is controlled by the brainstem. And I will give you the opportunity to read this slide at your leisure, but I'm going to kind of tell you in layman's terms so that you understand exactly how this is working. So like I said, the respiratory center controls respirations by way of the spinal cord and the phrenic nerve. And this activity is regulated by chemoreceptors. So here we go. You have chemoreceptors throughout your body, mainly in the aortic arch, but you do have some peripherally. And they are very sensitive to changes in carbon dioxide levels in the blood and hydrogen ions. Okay, so if your body senses that there is too much carbon dioxide in the body, your brainstem says, breathe faster, breathe harder, breathe deeper, get this carbon dioxide down. So you want to blow off more carbon dioxide. And remember from our ABG lecture, carbon dioxide levels are supposed to be between 35 and 45. So if your carbon dioxide level is 70, your body is going to say, breathe, 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 breathe. Let's get rid of this. Once your carbon dioxide level goes back down to normal range, which is between 35 and 45, then you can start breathing normal again. Your body's mechanism says now you can breathe normal again. So that's basically what this slide is telling you. I need you to know the priority is always going to be about how much CO2 is in the body. Okay, that's kind of how the whole thing works out. This second slide continues because I need you to understand this. There's about 15% of people that walk around, maybe even 20% of people that walk around, and they don't operate like me and you. We have healthy lungs, so CO2 goes up. Brainstem says, breathe, 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 and we do. There are people, their body responds the opposite way. They actually respond by having low oxygenation levels. So when they get to a certain low, their body says, hey, breathe in that good, rich oxygen so that we can get your oxygen level up. It does not respond to high levels of CO2 because they are used to having high levels of CO2. So basically, their body believes that's its norm. So if we give them too much oxygen, because we just love giving people oxygen, throw them on liter, 2 liters, 2 liters, nasal cannula, 2 liters. If we give them too much oxygen, they have no stimulus to tell them to breathe for more oxygen because we're giving it to them. So we end up saying we will kill the hypoxic drive. So their body's drive to breathe is from hypoxia. We call those patients COPDers, okay? And I hope I explained that really well. If I didn't, reach out to me and we can talk about it a little bit more. If I didn't, reach out to me and we can talk about it a little bit more. Respiratory problems. So if you have a respiratory problem, it's going to be one of the three things going on. You're going to have either a decrease in oxygen supply, a decrease in absorption of the oxygen that is available, or the transportation route is not good. All of this is going to interfere with gas exchange. And I think that's a very important point. So we're going to go on to talk about how do we know who's at risk. Risk factors. People that are going to be more at risk for having issues with respiratory. We're going to start off with our seniors, people that are older than 65. We're going to move on to talk about our patient who smokes cigarettes, our people that live in extended care facilities, and that I'm going to say crowded areas, crowded living, barracks, dorms, jails, shelters. If you already have a chronic respiratory disorder, congenital or cardiovascular disease, chronic renal disease, if the kidneys are tripping, they're not going to produce erythropoietin. Erythropoietin asks the bone marrow to give more red blood cells. And remember, red blood cells via the hemoglobin is what is providing this oxygenation. If you have diabetes mellitus or other chronic metabolic disorders, or if your immune system is suppressed. Hold on, there's more. Allergies, chest injury, exposure to chemicals and environmental pollutants. You're a construction worker working with asbestos, you work at the funeral home, and you are subjected to the chemicals that they use there to embalm the body. You have a family history of infectious disease. You have frequent respiratory illnesses. Depending on where you live, resident, and if you've traveled out of town. Remember, people who live at high sea levels have a reduce in oxygen, so they end up having a decrease in PaO2. If you have just recently had surgery, not only smoking tobacco, but chewing tobacco as well, viral syndromes, and the malnourished patient, poor nutrition, it could be malnourished, it could be obesity. So I don't want you to forget about that. This next slide I had to throw in because occasionally you do have to get some terms out of the way. You can go over this at your leisure. I want to add hypercapnia, Hypercapnia, and that is increase in carbon dioxide. Remember, the normal range of carbon dioxide is 35 to 45. And hypocapnia, which is a decrease in carbon dioxide. You don't want to forget about the assessment. Now, since we have the risk factors out of the way, we know how the respiratory system works. Now this patient is coming in and they're going to talk to us about some stuff. And we need to make sure that we do a thorough assessment so that we know exactly what's going on. I want you to know the exact questions that you need to ask. And I need you to know, get a good family history. So the first things you need to ask this patient is, where do you live? So like I said, have you been out of town for a while? You want to know about smoking, their family history, and get a good idea of what's going on with them as far as that. When we talk about smoking, we call those pack years. And I want to give you a good understanding of what a pack year is in case you have to calculate this on the test or anything. A pack year is 20 cigarettes a day for 1 year. 20 cigarettes per day for 1 year. So patient comes in and tell you that they are a smoker. Obviously, you're going to ask them how much they smoke. They're going to tell you, I smoke 10 cigarettes a day. And you're going to ask them, for how long have you been smoking 10 cigarettes a day? And they're going to tell you for 6 years. That's going to be half. So they are going to be considered a 3-pack year. They have smoking for 3-pack years. Second example is where a patient comes in, they smoke 40 cigarettes a day, so they're 2 packs, and they've been doing this for 20 years. So they would be their pack years would be 40 pack years. If you need a little bit more understanding about that, go ahead and Google it. It's pretty obvious. We've been doing it like that. Drug use. You want to know if they're doing any illegal drugs, and you also want to make sure you talk to them about over-the-counter medications, prescription medications, herbs or vitamins that they may be taking. Allergies is very important. You want to talk to them about allergies. Remember, allergies and asthma and all of that, especially with our pediatric patient, is very important to know. Have they had any travel out of the country? That is very important. You need to talk to them about their nutritional status, and you can kind of, take a good look at them and figure out what's going on. The questions about respiratory that you really want to focus in on: do they have a cough? And when they tell you they have a cough, you need to know, is it a dry cough or a moist cough? Do they have sputum with this? Okay. And then we need to talk about chest pain. Make sure when you are talking about chest pain that you ask them key questions, because you want to differentiate between cardiac chest pain and respiratory chest pain. Cardiac chest pain is going to be chest pain that's going to happen. It is not exacerbated by taking a deep breath in. It is usually not, the patient normally can't point right here on the side. It's usually not going to increase or decrease with movement, whereas respiratory chest pain is going to do all of that. Pleurisy, you can point to the exact same spot. Breathing in and out, causing pain, pneumonia. So you want to make sure that a patient that's been moving, helped their son move last night, may have some intercostal muscle pain, and that's costochondritis. You want to ask them, are they having any difficulty breathing? If they tell you that they are having difficulty breathing, you want to find out, is that when they're doing things? So that's when we'll say they have dyspnea with exertion, or is it when they are just sitting still and they all of a sudden have difficulty breathing? You also want to talk to them about, and I abbreviated on here, I'm sorry, PND is paroxysmal nocturnal dyspnea. That's going to wake you up out of your sleep, and it's going to cause you to have some difficulty breathing. It comes on sudden and then goes away. Paroxysmal nocturnal dyspnea. Paroxysmal. Nocturnal dyspnea. And the last one is orthopnea. Orthopnea is the inability to lay flat. It causes you to have a hard time breathing. And so we all have an uncle or aunt or a grandmother or someone who sleeps in the recliner chair. So they have to almost sleep up. Sometimes we'll ask them, how many pillows does it take? Because they have to prop themselves up on 4 pillows in order to be comfortable in the bed. That's orthopnea, difficulty breathing, laying flat. Go back to your sputum production. Remember, when they tell you they have sputum production, it's not just a yes or no. As a nurse and doing a full assessment, you need to make sure you document the amount of sputum, the color of sputum. Is it green? Is it tan? Is it clear? You need to know the odor. Does it stink? The consistency. Is it thin or is it thick? Okay. And how often they're coughing it up. You might want to even go as far as to say, is it bloody? Is it purulent? Those are the things that are very important. You also might want to ask them questions as far as immunizations. Are they current on their immunizations? The TB test for tuberculosis, pertussis, polio. Not that we really have to worry about polio. Their pneumovax and their influenza shot. Those are some things you want to ask your patient about too as you're doing your assessment. As a nurse, as you are looking at your patient, you need to make sure that the respiratory status is adequate to meet the metabolic demands all the time. So one of the things you can do is take a look at your patient. Are they breathing fast? Are they leaning forward? Are they speaking in complete sentence? When they got up to stand on the scale, were they having a hard time breathing? Take a look at the skin color so you can see about the gas exchange. Now, once a patient starts having skin color changes, capillary refill changes, oral mucosa changes, at that point, we're pretty much past having a little respiratory issues. We're, kind of late stage right now. And then look at the general appearance of your patient to find out if the respiratory status is adequate. Now, of course, we cannot move on without doing a physical assessment. It is very important that you systematically listen each and every time. Sorry about that. Each and every time. You start at the top, and you're supposed to start posteriorly. Start at the top and work your way down, comparing side to side, making sure that you have your patient, I say blow out the birthday candles because they tend to do that. Remember, as you have your patient take some deep breath, they will eventually cough in your face, so be prepared for that. You need to be paying attention to rate, rhythm, depth of inspiration, as well as looking for chest symmetry. Make sure that when you are doing your assessment, you are always following normal assessment, which is look, listen, and then feel. You want to make sure that you are paying attention to lung sounds and trying to identify them. I'm going to actually have you listen to some lung sounds and see if you can identify them. The first one I'm going to have you listen to is bronchial and vesicular. The first set is going to be bronchial, and the second set will be vesicular. Maybe I will, maybe I won't. It just all kind of depends, doesn't it? All right, let's see if we can get it going. So that was your first sound there. The second ones, I'm going to see if you can identify yourself. That's absolutely right. Whoever said that the first one was fine crackles and the second one was coarse crackles did a really, really good job. There's your rhonchi. Definitely. Last one, guys. And once again, I chose this one because I wanted you to be able to notice when it is not your textbook sound. And if you said that that was wheezing, you're absolutely correct. It's not your typical whistle, but it is definitely wheezing. So, guys, there are lots of lung sounds on YouTube and different, and probably that came with your textbook. So listen to those sounds, because now on boards they are putting hot spots. So they will say, push here, and what sound do you hear? And so you need to be able to identify lung sounds. This next slide, I just wanted us to put a summary of where you're hearing these lung sounds at. So whether it's tracheo, bronchial, or down in alveolar, which is always going to be your crackles. Just a little summary. And so when you are flipping back through this PowerPoint a little bit later, without the sound, you will be able to identify where these sounds are actually coming from. So we have actually covered talking about how the respiratory system works, what these patients come in complaining of. If we have a problem, what is the problem? What's the cause of the problem? Now we need to diagnose this problem. We need to find out exactly what's going on. This is where we do our diagnostic tests and procedures. So the first thing that we normally do is we'll do something non-invasive. We'll probably have them come in and get some blood. Phlebotomist comes into the room and we do quite a few blood tests. The one blood test I definitely want us to focus on is going to be our arterial blood gas, our ABGs. Okay? Like I said, I have a whole video on ABGs, so I'm not going to tell you how to interpret them. But just for the sake of repetition, I will tell you that your ABG measures your pH in your blood, your carbon dioxide in your blood, your bicarbonate in your blood, and your oxygen saturation, your partial oxygen saturation in your blood. And as a nurse, what I need to do is explain this procedure to my patient and let them know everything that is going on. I need to make sure that whoever is taking this blood or getting this sample does an Allen's test on my patient, and the Allen's test is to check for collateral circulation. I want to make sure that if by some chance we damage the radial artery, that the ulnar artery can still perfuse the hand. So remember, this is the test where we close your fist, cover both of the arteries, the radial and the ulnar, and open up your hand. Your hand should be all nice and white from closing it really tight and then occluding those arteries. And then when you open up your hand, it's white. You remove your finger off of the ulnar artery and your hand should pink up, meaning that the ulnar is patent enough to perfuse the hand if by some chance we damage the radial artery. That is very important for us to talk about with our patients. Another thing is we want to make sure we explain the procedure to them. And then afterward, we want to make sure that we apply pressure to the artery. 5 minutes is usually the standard if your patient is not taking an anticoagulant. If your patient is taking an anticoagulant, and I'm going to say your Lovenox and your heparin, and then I'll go one step further with aspirin, which is not an anticoagulant. It is an antiplatelet aggregator. But any of those that may increase the likelihood of your patient bleeding, you want to hold pressure. Okay, the D-dimer is another test. It is a blood test, okay? And a D-dimer is a test that we take to assess for thrombin and plasmin activity. You don't have to fast for anything like that, but it is very useful in diagnosing pulmonary embolisms and DIC. And when I say DIC, I am referring to disseminated intravascular coagulation, and we will talk about that a little bit later as we talk about a lot of disorders, and probably in our cancer chapter. So we want to make sure that we explain what's going on with that. The next thing I want to talk to you about is sputum collection. And this is a procedure that we're going to do by expectoration, or you could do it by suctioning. And we want to make sure that we do this first thing in the morning. And this is your culture. You're going to send this down to look for abnormal cells or the identification of any kind of microorganisms. So first thing in the morning, have your patient rinse their mouth out before collection. And you want to make sure that they're not spitting, that they're taking nice deep breaths and giving you a great cough or a great hawk. Okay, so you want to make sure that you do this. And like I said, most important is you want to make sure they rinse their mouth out before that. You want to transport this specimen to the lab immediately. And with any culture and sensitivity that you are doing, you want to always make sure you get your sample or your specimen before starting antibiotic therapy. Another specimen that we get is the acid-fast bacilli, and that's going to be for your TB. It may be collected on 3 different days, and we usually do that one first thing in the morning as well. This is going to look for the acid-fast bacilli for us to find out if it is positive or not. Another one that needs to be sent down to the lab promptly. We also do a skin test. And we're going to do that we can check for allergies, and we can also check for TB. That's the one that we're normally doing for. Remember, this is an intradermal injection. We're getting that little bleb right up under the skin. We're always going to do it on the forearm, and sometimes we'll circle it. so that whoever is reading it, when the patient comes back between the 48 and 72 hours, they will know that that's where we are at. Remember, we are measuring area of duration, not redness. A positive result is going to mean that the patient has been exposed. It does not mean they have active disease. And an duration of 5 or greater, it indicates recent exposure or possible HIV infection. Remember, everything is followed up with a chest x-ray. And an duration of 10 millimeters or greater is going to be pretty much probably the findings of active TB infection. Then your negative results will be no induration and maybe some redness or anything like that, but we don't have to really worry about that. The next thing we're going to talk about is the chest x-ray. Chest x-ray, not a really big deal. I'm sure you guys know about that. Once again, we're going to make sure our patient can hold their breath for a couple of minutes and stay still so that we can get the chest x-ray. Our next thing is that we're going to make sure that she is not pregnant, remove all the jewelry. And the chest x-ray is basically going to provide anatomical location and appearance of the lungs. So now this is where we get a little bit goofy because we have to talk about the laryngoscopy and the bronchoscopy. The bronchoscopy, both of these oscopies are direct visualization of the larynx, trachea, bronchi, and use of a fiber optic bronchoscope. So if you think about what I'm saying, you're taking a scope and you are looking down a person's throat to see if we have any abnormal tissues or structures or anything like that. So that sounds pretty invasive to me, and so we need to get a consent. We need this patient to be NPO for at least 6 hours. We need to get a baseline set of vital signs, check coagulation labs. That's your PT, PTT, PTINR. Remove the dentures, remove glasses, have emergency equipment available, have suction available. The NPO for 6 hours at least, and we normally do NPO after midnight. That is very, very important, okay? We're sticking the scope down there. We do not want this patient to vomit and aspirate. That's the most important part. When the patient comes back from getting a bronchoscopy, and remember, when we do the bronchoscopy, we can go down there with the scope. We see something goofy, we can biopsy while we're down there and come on back out and then send that to the people. When they come back, we need to keep this patient in semi-Fowler's position. We want to make sure that they can protect their airway. We have numbed it so that we can stick that scope down there. We have relaxed their gag reflex, so we're going to check their gag reflex. And we're going to monitor for signs and symptoms of complications. This is what I believe is important, guys, and I want to throw this out. So here, listen to me if you dozed off for a second. Monitoring for signs and symptoms of complications. I'm going to tell you what those complications are, but who cares? I need you to know how they look, how they are clinically manifested for your patient. So, boards. Your patient is 3 hours back from a bronchoscopy, vital signs or X, Y, and Z. You need to know those vital signs say that this patient is hemorrhaging. So you need to be looking at, does this patient have a fever? Does this patient have an increased heart rate? Is this patient tachycardic? Is this patient hypotensive? Those are going to be the vital signs you would be looking at. If they say the patient is complaining of pain, if they say the patient has gotten nervous and anxious, if they say the patient is saying that they're having difficulty breathing. Remember, we always do some kind of goofy assessment, so we're going to listen to lung sounds and check vital signs and stuff like that, and we're going to do that frequently until we feel our patient is stable. We're going to be looking for hemorrhaging and pneumothorax symptoms for at least the first 48 hours. So I don't want you to just know that the complications are bronchospasm, perforation, cardiac dysrhythmias, fever, bacteremia, hypoxia, hemorrhage, and pneumothorax. I want you to know how that looks in a patient. Will that patient look if they are having that complication? That's what boards is testing. Not that you remember what the complications are, but that you can identify them when the patient is at the bedside. Notify that dude if any of those symptoms happen, especially difficulty breathing. You stick a scope down somebody, you might puncture a lung. You want to make sure that the patient doesn't have a pneumo. The next thing I want to talk to you about is the pulmonary angiograph. So this is the one that we like to do. We don't do it too often You know, it's kind of ballsy. It's balls to the wall. But your pulmonary angiogram is going to look at, once again, you're going to have to get a consent, but it's going to be sticking dye through a patient's veins to see just how well they have flow through the pulmonary system. And we'll be looking for any structures or tumors or anything like that. So what we're putting in is iodine or some kind of dye or contrast medium. And anytime we're doing an angiograph, we need you guys to remember iodine, radioactive, or contrast medium is getting put in there. And your job is going to be to see if the patient is allergic to iodine or shellfish or dye. Okay? Of course, you're going to have to get a consent. And you need to educate your patient. Your role flipping from your medic or paramedic or your LPN is assessment and education. So tell your patient that they're going to feel some tingling. They may feel some flushing. They may get nauseous. It may taste salty. Because remember, the more informed our patients are, the better they feel about things that are going on. So that is our job as nurses to do that. Post-procedure, you're going to always get your frequent vital signs. You're going to avoid blood pressures in the extremity that was used. Because remember I said that we're going to put a catheter, put dye into antecubital or femoral vein. And then we're going to make sure that we do our neurovascular checks. So anytime we start messing with arteries and veins, we always need to make sure we do a neurovascular check and assess for bleeding. When I say neurovascular, I need you to think about the 5 P's. You are right on point, guys. Pain, pallor, pulses, paralysis, paresthesia. That is what's going to go on with your patient anytime we disrupt circulation. Pain, a change in color, a decrease in pulses. The patient won't be able to move the extremity, or they'll be having numbness and tingling. That's the paresthesia. So I want you to think about that. The next thing I want to talk about is going to be your thoracentesis. Now remember, these are your diagnostic tests and procedures. This is how we're going to diagnose what's going on with our patient. We need to basically rule out what the issue is. So your thoracentesis. A thoracentesis is the induction of a needle into the thoracic cavity. So each lung is covered by a pleural sac, okay? And it has a little lubricating fluid in that pleural sac. And sometimes that sac can fill with lots of fluid. And if it does, we need to get that fluid out, because obviously if there is fluid in between the pleural space and the lung can't expand. If the lung can't expand, then the patient can't breathe. If the patient can't breathe, then they can't get oxygen. If they can't get oxygen, they can't survive. That's the kind of thing. So we're going to remove air or fluid from the pleural space. And we're going to do this by a thoracic aspiration. Okay. We can take this fluid out and we can send it down to the lab and look at this fluid and see if it has cancerous cells in it. So it's a therapeutic thing. I mean, it's a diagnostic thing, or it could be therapeutic where we are instilling medications. And stuff, and use it as that. Another thing I want you to pay attention to is this has to be done strict aseptic technique. I'm sure you realize that because you are sticking a needle into the pleural space. The picture on this slide actually shows a lady who is positioned and ready to go for her thoracentesis. And that's it. It's usually done at the bedside. The patient is sitting up. They are leaning over on the bedside table. We tell them, do not move, do not sneeze, do not cough, and do not laugh. Don't turn your head looking back here trying to see what my doc is doing. That's that. So, pre-procedure, we are going to get a consent. Got to get a consent whenever we're sticking needles in people's back. Okay. And we're going to get vital signs because we need baseline vital signs. We definitely need to get coagulation level studies, your PT, PTI, and RPTT. Position your patient. Tell them no coughing, no breathing, no movement during the procedure. And then post-procedure, once again, frequent vital signs, respiratory status. Listen to the lung sounds, please, guys. No problem if it's an order, or if you can get an order for a chest X-ray. Make sure no one that when we went through that little bit, because it's a small area between the pleura and the lung, and you want to make sure that you don't have a slow leaking pneumothorax. You want to check for bleeding at the site. You want to check for crepitus. Remember, that's going to be the little air bubbles up under the skin, meaning that there's air seeking out. Monitor for signs and symptoms of a pneumothorax, an air embolism, or a PE. And then auscultate lungs, sounds, please. Remember, it's not that I want you to remember what the signs and symptoms are. I want you to know how they look in the patient so that you can identify them. I also need you to move on to chart what you took out. You can take out a lot sometimes. I've seen them take out 1,000 before. Anyway, you need to make sure you chart the amount and the appearance of the fluid and the condition of the patient. Was they able to tolerate this? Most times, if they have a lot of fluid in that pleural space, when they take that fluid out, your patient looks so much better and they're able to breathe. If by some chance, an hour after Dr. Dan decides to take out the 500 milliliters of nasty fluid that you had to put into another container to send down to the lab, yep, that'd be you, and you go into your patient's room and you say, Ms. Johnson, how are you feeling? Let me get these vital signs. And she is tachypnic and her lips are blue, and for some strange reason she say, I've been coughing a lot. And look, and she shows you the sputum and it's a little, I don't know, rust color. You listen to her lung sounds and she sounds a little diminished on the left or the right or whatever. You want to make sure you tell somebody immediately. Once again, I'm trying to get you in the habit of knowing what the patients will say. And then last but not least, we're going to talk about the ventilation and perfusion scan. You will hear people call it the VQ scan. This is going to evaluate the perfusion of blood flow to the lungs. The ventilation scan determines the patency of the pulmonary airways. It's very diagnostic. We use it for testing for PEs. So that's another one. Pulse oximeter, remember, that's going to be your non-invasive one. Put the little probe on the finger, the ear. We got them across the forehead these days, the toes. Little babies get them on their foot. All kind of cool things. So that's actually not looking at the partial arterial pressure, but looking at the O2 saturation. The one thing that I do want to tell you is making sure that you don't have cold extremities. And I might be overstepping. I'll talk a little bit more about the pulse oximeter. And then the capnography. Capnography is going to be determining the amount of CO2. So the CO2 level. So, there used to be a time when we were all into O2 levels, and now we've gotten a little sophisticated, and now we care about CO2 levels as well. So one of the things I want to tell you guys about is what we do. Okay, so now we've done some diagnostic stuff. We need to make sure that we are talking to our patients, whether we're sending them home, whether our grandmothers call us because they had surgery, they just came home from the hospital, they've been diagnosed with pneumonia, or whatever the situation is, on what's important that's going to promote good oxygenation and lung expansion. Walking is very important. Coughing and deep breathing is very important. Making sure the patient is positioned is a good spot. So we always know that sitting up is going to maintain the best way to have lung expansion. So you want to think about that. Using the incentive spirometer encourages the patient to take a deep breath. And if you ever get an opportunity to play around with the incentive spirometer, do so. Because remember, you are actually breathing in and holding that little ball and letting it dance between the two indicators. And so then we have some non-invasive positive pressure airway things such as your CPAP and stuff like that. So our job is education. So I want you guys to not get so caught up in seeing what the doctor is doing, anticipating what the doctor is doing, that we forget to educate on normal things. So if we don't have an incentive spirometer at home, we still can tell our family members to cough and deep breathe. Get up and walk and cough and deep breathe. So let's talk about oxygen therapy. So of course you already know about oxygen. I'm not gonna tell you everything I know about oxygen. or maybe I will. But anyway, it's a medication, so we need an order for it. Right, exactly. You knew that. We know it's essential to life, but even in it being essential to life, there are some disadvantages with it. At high concentrations, it can make things spontaneously combust. No. Anyway, you don't want to have smoke or fire around oxygen. It's not really good for that. And it is very drying to the tissues in the respiratory tract. So that's why we always we'll say in the world bubbler, but it's the humidifier. We'll put that humidifier on them so that it'll moisten mucous membranes. And then once you get an order for oxygen, if the doctor says, put the patient on 3 liters of oxygen via nasal cannula to maintain a O2 saturation of greater than 95, greater than 92, or whatever the situation is. That's our job. And sometimes they just tell us O2 at 3 liters or whatever, or O2, supplemental O2 to maintain sats above 90. And with that order, we have to determine what equipment we will use to deliver this oxygen. And our goal is to use the least invasive, the smallest amount of oxygen to achieve this goal. Oxygen administration. So just so you know, the air that we are breathing in right now is called room air, and it is about 21% of oxygen. So once we start thinking about supplemental oxygen, like I said, the purpose of the oxygen is to relieve hypoxemia. And I do want you to know the difference between hypoxemia and hypoxia. Hypoxemia is low levels of oxygen in the blood. So remember, anytime you see emia is going to be blood. And then hypoxia is going to be decrease in tissue oxygenation. So that's on a tissue level. Like I told you, our priority, our goal as nurses is to use the lowest amount of oxygen acceptable so that we can have our therapeutic response without causing any bad effects. Okay, so we'll need to collect our equipment. And, we're always going to be thinking about the source of the oxygen, the flow meter, the humidifier, the tubing, and what appliance we are going to use. But first thing we're going to do is we're going to find out what exactly is the oxygen saturation so that we can know. So you have your pulse oximeter. You're going to use this to see. Like I said, we can check it on fingers and toes and ears and skin and foreheads. It's best not to have on any nail polish if you're checking nail beds. It's painless. It's a non-invasive. You need a number. We normally like numbers greater than 90, greater than 92 works as well. With the population of where we are, that's kind of where we live. 95 and above for healthy lungs. You kind of know the drill there. What we need to do is we need to find out when we have to put on supplemental oxygen, what are we going to use? So now the doctor has decided to tell us to put on supplemental oxygen. And this is what we have here. The first picture is going to be the actual oxygen flow meter. This is the one that is actually in the wall. The bubbler is twisted on the bottom. If you see the bottom, it looks like a screw. Or we'll put a Christmas tree on the bottom of it. That's what we call it, but it's a connector. And then the tubing. The second picture is your, yes, nasal cannula. The third picture is your simple mask. The fourth one actually is a partial non-rebreather. I know we don't use it too often. Places don't buy it, but there is a such thing as a partial non-rebreather. Picture number 5 is a non-rebreather. And then your last picture is going to be your Venturi mask, which you will also hear people call the Venti mask, but it's Venturi mask. When you are deciding what appliance you want to use, it depends on the oxygen concentration that is required. And then you want to make sure you, if you need, what goal you're trying to reach or what disease process is going on, what kind of patient you have. Is it a confused patient? Is it a mouth breather? So you have to think about that. The comfort of the patient, importance of humidity, and the patient's mobility. Those things are all important. Sometimes we have to not think about those things, but it's most important that we do. So you know the flow meter. You turn the little green knob up front and there's a little black ball. If you can see it and it dances up and down or whatever, you turn it to where you want. The top is 15. So our nasal cannula. Our nasal cannula is going to give us about 1 to 6 liters. We can give 1 to 6 liters with the nasal cannula. It gives us somewhere between 24 to 44% of oxygen. It actually is no benefit to go greater than 6% because we have that anatomical dead space back there in your throat, so it doesn't really work. This is more of your long-term use because the patient can get up and move around with it, especially if you put connecting tubing with it. And I prefer that you put your patient on a humidifier if you go greater than 2 or 4, just depending. It does. It allows your patient to eat or drink and talk. So it does kind of. It works with the mouth breather, but it just kind of depends. Our second one is going to be our simple mask, and our simple mask you can get probably up to about 5 liters going there. It's 40 to 60%, and it's more for short term because nobody wants that big thing on their face. But it does prevent you from rebreathing the exhaled air that you've already let out. The thing is, you want to make sure you monitor this patient for aspiration. That is very important. It has the perforations on each side, so it helps out with that as well. We have the partial rebreather, 6 to 15 liters there, 70 to 90% of oxygen. Also, the patient kind of does the rebreathe about 1/3 of the exhaled tidal volume. And tidal volume is just the amount of air that's taken into the lungs with each breath. We want to make sure that we do not allow twists and kinks in the tubing, and please do not let the bag deflate. And that's true for the non-rebreather, same thing. Your non-rebreather, I'm going to say this is a little ballsy. When you see your patient on a non-rebreather, stuff ain't good. You'll be like, wait a minute, hold on. Why is this patient on a non-rebreather? This is going to be your highest concentration and can be delivered up to about 90%, like I said. It has a one-way valve that keeps the patient from rebreathing in the air. And it allows the patient actually to breathe in the entire amount from the reservoir of the bag and prevents room air from coming in. The bag needs to remain about 2/3 full. Don't forget that. And we usually turn this up to about 15 liters. The Venturi mask. This is the one on the end with all the little nice colors. This provides high flow of oxygen as well. It has an adapter. Those are the little adapters, yellow, white, green, pink, and orange, that allow you to select a desired amount of oxygen. So with this, you can pick up one of those little colors and look, and it'll say 24%, 35%, 55%. And so you can pick up the desired amount that you want for your patient. So if the doctor tells you, and we haven't ventilated the patient, the doctor says, I want the patient on 45%, you're probably going to go to the venti mask because you know that you're going to get that. Once again, it is a mask, though. You do have to put that together. If you get the opportunity in clinical practice, and I know we all come from various backgrounds, play with one of these, because when your patient can't breathe and you're trying to figure out how to put that together, it's not fun. Yes. From experience, me. Okay, so airway management. We know about the supplemental oxygen, and we know the appliances. Granted, this is not all of the appliances. This is the ones we see in practice a lot. And I wanted you to be familiar with them because I don't know when the last time you did it. Some of you guys are working in non-clinical areas. Some of you are working in clinical areas. Some of you are on the rigs. Yay! I missed the rigs. And so I just wanted to kind of put it out there for everybody to reach each and every one. And plus, I have some baby nurses that are not yet licensed that actually will get an opportunity to look at this video as well. So I need you to know how to manage your airway. Let's open up the airway. So airway management. We've been doing this for years. We all know this. As you can see, the head tilt, chin lift is the one we've been doing for years and years and years. The only problem with that is if we think that our patient could possibly have a spinal cord or cervical spine injury, we do not want to be tilting heads and lifting chins and stuff like that. So we would have to do the jaw thrust, where we do not touch, we do not move the actual neck or spine. We just thrust the jaw open, and you got to hold just right. And believe it or not, you'd be surprised at some of the things you have to do. It is a little bit challenging to thrust that jaw open like that, but it does open up the airway, and I can't talk about airway management without mentioning that. So definitely look at the difference between the two, and we'll go. So this next slide is what we use to get that airway open. So you can only hold that jaw open for so long, right? And then we have to move on to other ways to keep the airway open. So there are several things to relieve obstruction and protect the airway. And we have a nasopharyngeal airways, and we have oral pharyngeal, and then we have your endotracheal tube. So the first one at the top is the endotracheal tube. Remember, and I don't know, but remember, the balloon on the end inflates up. The two below are both just different sizes, your nasopharyngeal airways. And then the last two are just going to be your regular oral airway. Okay. Surprisingly, the two on the bottom of the picture, we actually stick them in upside down and then flip them over. The thing about the endotracheal tube is usually we'll start to have some serious pressure against the mucosa after about 7 days, and so we're checking pressure cuff, and then we may have to move on to a tracheal because the cuff pressure may be too high. So all of this is more your temporary stuff. Pictures, 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 and more pictures. Nasal and is the picture at the top. That's airway stuff, airway, and oral is the picture at the bottom for obvious things. I'm sure you can figure that out. So when we talked about short-term, temporary stuff, we have to talk about long-term, permanent stuff. With your tracheotomy, you could have it could be a long-term temporary thing, or it could be a permanent thing. And I want you, and like I said, I let you guys read the slides yourself. I'm just the voice behind the slides. I want you to know the difference. A tracheotomy is a surgical incision in the trachea. Obviously, the whole purpose is to establish airway. And then a tracheostomy is the actual opening. So you go to get a tracheotomy, and you end up with a tracheostomy. Hope that makes sense. Now, normally where I see students struggle is I'll have you guys in clinicals. I'll ask you to pull out a fenestrated drape or what's the cuff or something like that, and you guys just don't have the basic knowledge of what's going on with the trach. Boards have gotten fancy. They do all kind of goofy stuff. On this picture here, that's the whole trach set. The first picture is going to be a picture of the outer cannula and the neck plate. It actually has 2 holes in it where we put our trach ties. And then the second picture is the inner cannula. It actually goes in and then twists on. And then the last one, if you look, you're kind of wondering what that is. That's the obturator. It actually goes inside the actual outer cannula when we first put the trach in. And so if the trach becomes dislodged, and we're hoping that it never does, not on our shift anyway, we will use the obturator to put the trach back in place, hoping that that never happens. So normally when a patient has a trach, we will have the obturator right next to the patient is hard of hearing sign, just in case we have to put it back in. We have it taped right above the bed. So I just wanted to make sure that you guys knew exactly what that is. So this is your temporary one. We usually will take the inner cannula out and do whatever we need to do with it, throw it away, replace it, or clean it. I wanted to get a little bit more with talking about the trach, and I'm going to explain a little bit more about what's going on with the trach here. So like I said, we have trachs that are disposable or reusable. They are cuffed sometimes and not cuffed. As you can see, the cuff is just that little balloon that's on the end. The cuff, when it is inflated, it forms a seal against the wall of the trachea. Okay. The cuff port or the cuff balloon, just depending on the pilot balloon, whatever you want to call it, is where we actually put the the air in, and we can kind of squeeze it a little bit to see if we actually have it inflated. The neck of it, and they call it the face plate. The face plate actually is where the trach ties will go, and it also will have the manufacturer, the size, and that. You want to make sure that within the first 24 to 48 hours that a patient gets a trach, that you have 2 people there to help you with that trach, because that's going to be the chances that there, something's going to go wrong. Remember, you undo one side of the trach collar and tie that back in with the new one, and then you do the other one. You don't want to untie both at the same time. That's something testable. We like to ask that question. The obturator is on there as well. I want you to look at the picture at the very bottom that has the holes on the top of the trach. That's called fenestrated. Okay. And so I definitely wanted you to know about that. The inner cannula fits inside the outer cannula. And like I said, we can take it out and replace it or clean it. God, I really hope that you're not at facilities where you guys are cleaning trachs. That's the scariest thing I've ever heard. Normally, we just take the inner cannula out, throw it away, and put the new one in. And the obturator is the guide. We have to think about complications, and our goal is to prevent complications. Remember, there's nothing but safety, safety, safety all over boards. And one of the ways of preventing complications is to make sure that that cuff pressure isn't too high and that it does not cause mucosal ischemia. You want to make sure that you prevent malnutrition and hemodynamic instability. And for hemodynamics, I want you to think about vital signs. You want to make sure that you check the cuff pressure, you use the minimal leak and occlusive technique, and make sure you are checking those friction areas. Okay, make sure you don't dislodge that trach. Like I said, within the first 24 hours, definitely you want to make sure you have 2 people helping you. Suctioning. You do know we have open suction and closed suctioning. This basically is just a small overview of suctioning. We could probably go over suctioning like 4 or 5 more times before this is all over with. And I could probably tell you like 7 or 8 more things about suctioning. First thing I want you to know is that in order to suction your patient, you need to have your patient sitting up. That's not going to change. And explain to your patient exactly what's going on. So, hi, my name is Shamel. I'm going to be your nurse today. I guess they should already know that. But anyway, and I got to come in to do some suctioning. How do I know if the patient needs to be suctioned or not? I'm going to hear secretions. They can probably point and tell you they need to be suctioned. There's an order to suction them every 4 hours. We do not suction a patient every hour or anything like that. We don't do anything because remember that's going to be trauma going down there or anything like that. When we first put a trach in and you suction your patient, there is a possibility that you're going to get bloody return back. That's just kind of how it works. If you hear that nastiness and you always feel like, with your kids, you want to go down there and get it, that's a good reason to suction your patient. Gather your equipment, wash your hands. First thing you want to do is you want to increase the amount of oxygen that they have since you're going to interrupt it a little bit and stick something down their airway. So we call that pre-oxygenation or hyperoxygenation. And I want to use whatever words that you may come across. And so, be prepared to know that. We're going to do that. And then the second thing you're going to do is you're going to go in until you meet a little resistance and then come back about 1 or 2 centimeters, okay? And you want to make sure that you are not applying suction as you go in, but that you are applying suction, and that means putting your thumb on top of that hole as you are coming out. We are doing intermittent suctioning and kind of twirling the suction catheter in our hand. YouTube it, guys. Make sure that you understand exactly what's going on. Look, I was taught that you do not stay down there longer than 10 seconds. I am seeing a little debate, a little contradiction, and I'm seeing places where it is no more than 10 to 15 seconds. So what I want to do, as I have done a little research on your end, is I want you to go with 10 to 15 seconds, okay? And wall suction should be 80 to 120. Suction is important for maintaining airway patency and promoting gas exchange. Obviously, if there's gooiness down there, we can't have proper gas exchange. So we need to move that fluid out of there and get it up there. So like I said, coughing and deep breathing to help get that up there. Make sure that before you do this, you do assess the patient's ability to cough or not cough adequately. Suction is either done through the nose or the mouth, but you cannot go back and forth between the two in the one-time suctioning. Complications is going to be hypoxia, tissue mucosa trauma, infection, vagal stimulation, bronchospasm, cardiac dysrhythmias, or induced hypoxia. So here's the thing. I said don't stay down there longer than 10 to 15 seconds. In 5 seconds, if they turn blue, please stop. All right, cool. If by some chance they start to get tachycardic or bradycardic, please stop. Please do not go down there more than 3 times for me, please. If 2 times work, that's wonderful. If 1 time works, that's wonderful. But, sometimes we get overzealous and we want to get it, because we can still hear it. That's a lot on the patient, so do that. If you can, it would really be great if you can hyper oxygenate between each pass. And you want to make sure that, and that's hyperoxygenate or pre-oxygenate, whatever words that you're doing, that you are giving your patient enough time to recover each time. I know sometimes we get very busy in doing what we are doing, but we do not want to just be running down and, doing stuff like that for our patients. We have to make sure that we are looking out for our patients' best interests. Okay, so that's definitely something I wanted to throw out there. The next things we're going to talk about is when we're thinking about airway management is sometimes you do have to, you've tried all the things to work and you just got to go balls to the wall. So when you go balls to the wall, you're usually going to have something like mechanical ventilation going on. And that's when we start talking about intubating with the ET tube, what we discussed earlier today. First thing I want to talk about is what will cause us to intubate a patient, indications. So we do actually have a criteria, and I'm going to throw that criteria out there for you. Obviously, if your patient cannot breathe on their own, you know that you're probably going to have to breathe for them. Remember, we can breathe for them just with the bag valve mask. We don't necessarily have to intubate them and do that. So us nurses at the bedside before the team comes, we can bag our patient and breathe for them. But the real criteria to meet is going to be a CO2 level greater than 50. Now remember, guys, CO2, carbon dioxide, the normal rate is exactly 35 to 45. And then the second criteria is going to be a PaO2, not SaO2, but PaO2, partial arterial oxygenation, less than 50. Remember, your PaO2 is 80 to 100. It's not your SaO2, which is what you want greater than 90. And then acute changes to your pH. So a pH that is less than 7.34 or greater than 7.45, okay? That is the 3 criteria, okay? So obviously, I use the word work of breathing, and you'll see that sometimes as WOB. Work of breathing. Patient is having a hard time. They can't complete full sentences. They can barely walk over to the scale. They're having a really hard time breathing. Eventually, the lungs will tire out and be like, oh, look, I can't do this no more. Before that happens, we want to intubate this patient, okay? So those are some of the reasons that are indications for intubation. Some other things that I need you to think about when we are getting ready to intubate a patient. As a nurse, my job, I have responsibilities to this process. And one of the responsibilities is I do not let doc intubate my patient without me having a wonderful, and I do mean a wonderful working IV. Because if the stuff hit the fan, I need to be able to get something into circulation, right? All right. And second, I want to sedate the patient. You just can't be throwing tubes down people's throat without, sedating them. At the very least, you want to have a pulse oximeter at the bedside. Remember, every time we intubate a patient, it is not an emergency. So don't always think that you're going to intubate a patient because they're dying. No, they might just be breathing too hard, and we want them to relax so their body can recover, and we're going to just breathe for them for a couple of days. So here's my thing here. I'm going to make sure my patient is in the supine position with their neck hyperextended. We call that the sniff position. And then we're going to go right back to what I was telling you about going down someone's airway. We're going to hyperoxygenate or pre-oxygenate them before the doc attempt. with each attempt. He has 30 seconds to get the ET tube in. And if he can't, I'm going to hurt him. No. And then we need to go back to bagging, okay? So now Dr. Dan is great. He got it in. Everything is good. I have some more nursing responsibilities to do. And my next nursing responsibility after my patient is intubated is the first thing I need to do is, exactly, you guys are great, assess lung sounds. I need to make sure that I have lung sounds bilaterally because I need to make sure that tube is in the right spot. Okay, so there has been times that they've put it into the esophagus, and as soon as the respiratory therapist pushes that bag 1 or 2 times, you see that belly become pregnant, or the patient just throws up, and you're like, oh, I guess we wasn't in the esophagus. Remember, we've sedated the patient, so, you know, something like that could definitely happen. Another thing that'll happen that we have to be aware of, why it is important to auscultate bilaterally, is that sometimes the ET tube will slide into the right main stem bronchi. Remember I told you that it was wider, shorter, and straighter, and that things tend to go over there really quick? That's true. So and it happens more often than you would believe. So all you have to do is pull back a little bit because it just went down too far over to the right, and you want it right in between so that the air goes to both sides. Those are the 2 things that usually cause the issues. Once you have auscultated bilaterally, you want to also make sure that you are looking to make sure you have symmetrical chest movement. Another way, and that sounds really good, obviously the number 1 surefire way to make sure you've done it is chest x-ray. So we definitely don't want to forget about that. And then the chest x-ray is going to show the tip of the ET tube being about 3 or 4 inches above the carina. And then confirmation also can be done by a end-tidal CO2. So basically what we'll do is the respiratory therapist or whoever will bag the patient a couple of times. We will let them exhale the air out. Has no choice but to go out after it's been in. And then we will see how much CO2 they're blowing out. My next responsibility as a nurse is to secure the ET tube in place and mark where it ends at. So if we'll say that it's at the 40 cc's at the lip line or the teeth line, okay? So ventilator settings. Really important for us to know about ventilator settings. Some of the ventilator settings, and this might be a little bit more, but I think it's important for you to know because I think you need to start thinking about the respiratory disorders that we need to treat. Rate. When the doc talks about the rate of the ventilator setting, that's how many breaths we want the ventilator to breathe for the patient. Remember I told you it's not always, we don't always intubate a patient or put them on the ventilator because they cannot breathe. So if I go in and I'm taking care of Miss Smith and I will say, what is the rate on the ventilator set at? And if the nurse tells me the rate on the ventilator is set at 12, meaning that the ventilator will breathe 12 times every minute, I will say, is the patient breathing over the vent? So my question is their respirations 15, 20, or even 30? I want to know, are they breathing over the vent? If the patient's respirations are 12, then that means the vent is breathing for them. Okay. That rate actually means that when the patient doesn't decide to breathe 12 times, the ventilator will be there to help them out. Tidal volume. Don't get all excited about these words. Oh, she's bringing in big words. Nope, that's just the total amount of air that you breathe in your lungs and each breath. FiO2. The FiO2 is your fraction of inspired oxygen. It is usually represented as a decimal. So it'll be like 0.4 or whatever. That's 40% of oxygen that is taken in. So just so that you'll know that. And then your PEEP. I think PEEP is very important. It's one of those things I kind of like it. It's your peak end expiratory pressure. And it is the amount of pressure left inside the alveolar at the end of expiration. And you want to keep a certain amount of it there so the so the alveolar does not collapse. It helps with gas exchange. Yeah, I see you thinking, yeah, kind of how it works out. Surfactant kind of works, okay? It keeps a certain amount of pressure at the end, and that helps out with gas exchange. Just remember, the PEEP is usually somewhere between 3 and like 20. Normally, I see it a lot at 5. So we'll tell you that the rate is 12, tidal volume is 500, FiO2 is 40%, and the PEEP is 5, and that's centimeters of water. The higher the PEEP, the more increase of pressure you've put in the thoracic cavity. You're going to decrease your patient's blood pressure. Okay, yeah, let's move on. Complications, ventilator alarms. When you think about ventilator alarms, I will probably guarantee you that on boards, this question that I am about to throw out there is going to be on boards. I can almost guarantee it. The ventilator makes 2 alarm sounds that you, as a nurse, can mess with. And that is the low pressure alarm and the high pressure alarm. The low pressure alarm means something is disconnected. There is low pressure somewhere between the patient that the ventilator is attached to and the ventilator. My job as the nurse is to check to make sure there is no disconnections or openings or anything like that. So I'm going to check. When I see the high pressure alarm go off, I'm going to start at the ventilator and work my way all the way to the patient and look and see, make sure everything is connected, all the things are connected tight. There's no leak in the system. Low pressure. A high pressure alarm means that the pressure within the system, meaning your patient and the ventilator, is high. Things that would make high pressure is your patient is coughing, because now the ventilator is trying to send air to your patient and your patient is coughing out. That's going to increase the pressure. Your patient is sneezing. There is a mucus plug, so you need to suction your patient. We will say, you'll hear old school nurses say the patient is bucking the vent. As young school nurses say, the patient is fighting the vent. When your patient is bucking or fighting the vent, call it what you want, the patient need to be sedated so they can chill out, basically. So we have a mucus plug. We need to suction it out. The patient's coughing, or the patient is fighting the vent, going against the vent, breathing against the vent. What I need you to know is those are the things you need to do if one of those alarms go off. Check for connection, suction your patient, sedate your patient, or whatever. If by some chance you address this issue and the alarm keeps going off, your job as a nurse is to disconnect that patient from the ventilator and manually bag them into respiratory, and they can troubleshoot. If the alarm continues to sound after you've done all your troubleshooting, you need to take the patient off the ventilator and manually bag them. I bet you're like, really, chick? That's what you want me to do? Yeah, sort of, kind of. Always treat our patients, don't forget. Our nursing goals. Guys, don't forget our nursing goals. Our nursing goals are set for promoting oxygenation, preventing infection. If we talk about hand hygiene one more time, I think we'll kill ourselves. But hand hygiene is very important. Once our patient has had these issues with respiratory infections, we need to educate them on staying out of crowded areas, especially during the cold and flu season. Make sure they stay current on their immunizations, refrain from smoking, avoid the allergens, especially if they know what they are, maintain adequate hydration, and get sufficient rest, and try to keep a healthy immune system. So we are also to prevent further lung damage, which is to do some of these things, especially like refrain from smoking, and then promote rehabilitation. Okay, so I wouldn't be cool if I didn't put these questions on here. So let's go over some of these questions. The nurse is caring for several patients who are scheduled for diagnostic testing for a respiratory disorder. The patient who needs post-procedural care that include frequent vital signs is the patient who had. So A is capnography. Now, do you guys remember what capnography was? If you said that is how we check carbon dioxide levels, you are absolutely right. B is the D-dimer test. Do you guys remember that one? Okay, D-dimer. Yes, it was a blood test to check for thrombin and plasmin. Okay, and that is to see how well the activity that they work in. Is a patient at risk for blood clots? Ventilation and perfusion scan, and that's for the pulmonary circulation to see if everything is going well there. And then a bronchoscopy is the scope down the throat, looking to see what's going on in the bronchi. If we see anything goofy, we're taking pictures, and we may actually do a biopsy. So we've got the 4 choices. Let's go back and figure out exactly what the question is asking. The patient who needs post-procedural care that includes frequent vital signs. So we need to know which one of these patients is getting a procedure that will require us to do frequent vital signs. Frequent vital signs to me says that I need to monitor this patient closely. So for me, I'm saying which one of these patients is most likely to go bad? Which one of these patients are at greater risk for having a complication? Exactly. If you thought about the bronchoscopy patient, you were absolutely right. Because remember I told you the bronchoscopy patient was one at risk for aspirating because we gave them the sedative, made them NPO and all that. And also, your bronchoscopy patient is at risk for a pneumothorax. We are sticking a scope down their throat and the doctor might go down too far. There could be a risk for hemorrhaging. Lots going on. The first one is very invasive. The capnography is just like getting a pulse oximeter. The dimer is just a regular blood test. Phlebotomist comes in and draws some blood. And the ventilation and perfusion, not saying that that one's not a bad one. That one we could have some issues with as well as far as bleeding. But the bronchoscopy is the one where the frequent vitals definitely need to be done. I'm sure you guys did really good with that. All right, here's our second question. Immediately after the physician intubates a patient who is in respiratory arrest, the nurse notes that there are no breath sounds in the left lung field, but breath sounds are heard on the right side. The likely explanation is that A, the tube is in the esophagus, B, the tube punctured the left lung, C, was inserted too far, or D, is malfunctioning. I actually think this is a really good question. This is a question I would definitely want to put on the test. So I just told you what some of my responsibilities are as a nurse when my patient is getting intubated. And so the question here says, the stem of the question actually is, there are no breath sounds after the patient is being intubated. There's none on the left, there's some on the right. What could be the explanation? So my thing is, with A, the tube is in the esophagus. How do we know if the tube is in the esophagus? You're actually right. The belly gets big because you're putting air in the belly, or the patient throws up on you because you keep throwing air in the belly and they just eventually vomit. The tube is punctured on the left side. I'm not going to eliminate that one because there's a possibility, because there are no breath sounds on the left side. So that is a possibility. And then, but you do hear them on the right side. And let's see. This tube was inserted too far. What does that mean? All right, we can leave that one in too. Malfunctioning, the tube is fine. We hear breath sounds on the right side. So we're kind of stuck with B and C. And remember I told you earlier in the presentation that the right main stem bronchus was shorter, wider, and straighter. Yes, so we inserted the tube too far. We have to pull it back just a little bit, and that will usually help out with that. Here's another question that we can do. When the nurse places the diaphragm of the stethoscope over one of the main bronchi, the expected normal breath sound heard is, and that's the funny thing, you can't even go back to the screen where I told you. This is one of those you have to know the answer, the bronchiovesicular breath sound. This is memory recall. There is really no test-taking strategy behind it. Our next question is, the nurse is observing a nursing student who is suctioning a patient for excessive secretions. The nurse would intervene immediately if the student, A, pre-oxygenated the patient with 100% of oxygen for 2 minutes. Okay. B, applied suction while inserting the catheter. C, set the wall suction gauge for 80. D, monitor the patient frequently for tachycardia or bradycardia. So the question, if we go back to the question and look, there is a nursing student that is suctioning the patient, and I would intervene, stop it, go in and say something, wait a minute, immediately. They say intervene immediately. So that means that the nursing student has to be doing something wrong. Pre-oxygenating the patient for 2 minutes is cool. Setting the wall suction has to be between 80 and 120. Monitor the patient for frequently for tachycardia and bradycardia. Remember, those are your cardiac dysrhythmias that we were talking about earlier. We do not apply suction while inserting the catheter. We apply suction while removing the catheter intermittently, and we also twirl the catheter. So very good if you said B, apply suction when inserting the catheter.